Hello and welcome to the webinar today. Looks like a few people are still joining us and our attendees are filling in on this GoToWebinar. We're going to wait just another moment for those to kind of load, and then we'll get started in just a moment. While we're waiting, it looks like there's still a few attendees who are kind of joining on. Feel free to chat in where you're coming from. Where are you in the country or the world? What practice are you at, or what location, what town, city are you in? Go ahead and chat in. I see some people starting to chat in either the question box or the chat box is fine. Excellent. Okay. Wow, lots of different places. I'm seeing Florida, Alaska, Seattle, Detroit, Columbia, South Carolina, Rockaway Beach, Kentucky, Oakland, Salt Lake City, Tennessee, Texas, lots of Texas. Wonderful. It is great to have you all here with us today. So we are going to go ahead and get started with our webinar today on adolescent-centered contraceptive counseling, adopting a shared decision-making model with adolescents. My name is Jenny Lane. I'm the Senior Program Manager at the Adolescent Health Initiative. I'm going to take us through a little bit of our housekeeping and get us started. So we are going to save some time at the end of this webinar for questions and answers. But if you have some questions that occur to you throughout, you can feel free to enter them as they occur to you, and then I'll save them and we'll moderate that part of the conversation at the very end today. We will have at least 10 minutes at the end, though. We're going to protect that time for Q&A. You can either put that in the chat field or in the question box, in the Q&A box. And here is where that is, arrow to the questions. And it looks like this. You just type right into that field. It looks like quite a few have already done that with your location, which is great. A couple of other points. We're going to be recording this webinar and we will be sending you a link to the recording in the follow-up email. So for some context here, the Adolescent Health Initiative is providing this webinar for you today, and we've convened a couple subject matter experts for you. We're based out of the University of Michigan, and we provide training, technical assistance, consulting, and resource development to healthcare providers, to health systems, and to youth-serving organizations across the country. So at AHI, we don't provide direct service, but we work to support all of you who are on the front lines with adolescents and young adults every day. Our vision is to transform the healthcare landscape to optimize adolescent and young adult health and well-being. Today's webinar zooms in on one incredibly important component of adolescent health. We want to see a world where each young person controls their reproductive destiny, and we're delighted to convene our experts today to provide some concrete strategies to help you all make this happen in some very real ways. So our first presenter today, Dr. Otto, will be providing a framework for our discussion through the shared decision-making model for contraceptive counseling, with a particular lens of adolescents' developmental needs. She'll discuss some of the benefits and challenges of using this model and move into practice-based strategies. Our second presenter, Christina Arzate, will make things even more concrete by sharing an overview of the Contraceptive Choice Center's approaches to contraceptive counseling. Okay, now we're going to do a quick 3-question poll just to get a snapshot of where people stand right now. So when the poll question comes up, don't spend too long thinking about your answer and just go with your gut. Other thing I'll say about this first question is that it's about LARC, which is long-acting reversible contraception, which includes implants and IUDs. So going with your opinion only. First question, please. The poll is open. And the first question I'm not seeing it, but are folks seeing it there? Aha, great. The responses are coming in. So the question of how should LARC be presented to adolescents, thinking about whether you feel it should be highly encouraged, neither encouraged nor discouraged, or discouraged or strongly discouraged. See some responses still coming in. Looking like we're pretty evenly spread among the top 3 options here with highly encouraged, encouraged, and 37% is the majority, neither encouraged nor discouraged. So that's great. We've got 80% of participation in that. So that gives us a snapshot of where folks are today, with looking like that majority kind of in the more neutral phase with neither encouraging nor discouraging LARC. We're going to be talking about this quite a bit more, so this is a starting point. Oh, sorry, next poll question. Okay, next poll question. Provider bias can influence what contraceptive choices an adolescent is offered. Again, going with your gut, just thinking about how provider bias can influence what contraceptive choices an adolescent might be offered. So I'm seeing a lot of agrees and strongly agrees. Pretty much everyone is either agreeing or strongly agreeing, with the majority strongly agreeing with the statement that provider bias can influence what contraceptive choices an adolescent is offered. All right, thank you for your response there. And last question. Adolescents are fully capable of making informed, health-promoting decisions about their contraceptive choices. So just go with your gut on this one. Adolescents are fully capable of making informed, health-promoting decisions. Okay, seeing some responses here, kind of almost evenly matched between agree and disagree, still with 18% at neither agree nor disagree. So yeah, about 19% in the neither agree nor disagree. So maybe reflecting some mixed feelings on that one because of the language like fully capable, health promoting decisions. But we've got a 29% at strongly agree and 42% agree with that statement. All right, we'll close that poll, and we thank you for kind of just taking that moment to reflect on some of your thoughts and feelings and values around contraception in adolescence. And hopefully this reflection on your own values, as well as the pulse of the group, will be useful to you in the rest of our session today. Okay, I'm going to give you some background on our speakers. Dr. Alana Otto is Assistant Professor of Pediatrics in the Division of Adolescent Medicine here at U of M. She trained in pediatrics at Northwestern University and Lurie Children's Hospital, Chicago, and completed fellowships in academic general pediatrics and primary care at Lurie Children's, and then in adolescent medicine at the University of Washington and Seattle Children's. She also completed the University of Washington's Leadership Education in Adolescent Health, or LEA Fellowship program. And her clinical interests include adolescent sexual and reproductive health, as well as gender-affirming care for transgender and gender-diverse youth. Christina Arzate is a contraceptive counselor and community outreach coordinator for the Contraceptive Choice Center at Washington University School of Medicine. She has a background in suicide crisis intervention, positive youth development, and sex education. Christina is originally from Los Angeles, where she received a bachelor's in community health from Cal State Dominguez Hills, and she moved to the Midwest to pursue a master's in public health from Washington University in St. Louis, with a focus in data analysis and violence prevention. Christina's interests focus on criminal justice and sexual health, specifically access to sexual health education and services among justice-involved youth and adults. So now I'm going to turn this over to Dr. Otto to take it away.
Thank you, Jenny. All right, good afternoon, everyone, or good morning, depending on where you are. Providers who counsel patients about contraception need to convey a lot of information about many different methods, usually in a very short period of time. And historically, providers were not given a lot of guidance as to how to do this. In the last 10 years or so, there has been a lot of enthusiasm for a model called tiered counseling, which instructs providers to organize methods by effectiveness and discuss the most effective methods first. As a bit of background, modern long-acting reversible contraceptive or LARC devices became available in the United States in the early 2000s. Initially, uptake of these devices was limited. Although many patients valued highly effective methods of birth control, they faced barriers to using them. For adolescents in particular, a common barrier was reluctance on the part of providers to discuss LARC with young patients. As it became clear that LARC are safe and effective for young people, enthusiasm about their use among adolescents grew, and we began to see efforts to increase adolescents' access to LARC. In particular, in the late 2000s and early 2010s, we saw widespread recommendations to adopt this contraceptive counseling strategy called tiered counseling in an effort to encourage providers to discuss LARC with adolescents. Tiered counseling is also sometimes called LARC first counseling, again, because LARC methods are presented first and they're often emphasized by the provider. And this strategy can often be directive, meaning it has a goal of getting patients to use LARC. Tiered counseling assigns value to methods. It says some methods are better than others, and this value is based solely on effectiveness. This emphasis on effectiveness, together with the fact that LARC methods are very easy to use, has translated to a paradigm in reproductive health whereby LARC methods are often conceptualized and described as the best or first-line recommendation for folks seeking contraception, including adolescents. In the last 10 years or so, however, folks have increasingly expressed concern about potential problems with this approach that views LARC as first line for all people. One of the potential pitfalls of this approach is related to the United States history of promoting LARC to particular groups in order to limit or control their reproduction. And to fully understand the implications of this history and how it relates to LARC use today, we need to be familiar with the concepts and histories of stratified reproduction, reproductive coercion, and reproductive justice. Stratified reproduction is a concept used to describe power dynamics around reproduction in society, and the observation that society does not value all people's reproduction equally. Some people are encouraged to reproduce, while others, including people of color, poor folks, young people, those with mental health or substance use disorders, those who are incarcerated, these folks are discouraged from reproducing and may even be criminalized when they reproduce. A related concept is that of reproductive coercion, which refers to practices that limit an individual's reproductive autonomy. And this includes practices that attempt to control or unduly influence decisions around contraception. Reproductive coercion can occur at the system or societal level as policies and programs that discourage or prevent pregnancy and childbearing among specific groups. In the United States, this has included the forced sterilization of at least 70,000 women, which, as many of you may have heard in the news recently, has occurred as recently as 2020 in this country. There's also an extensive history of coercive use of LARC in the United States, which is particularly relevant to our discussion today. And in particular, Norplant, which was a contraceptive implant available in the 90s, was misused in a variety of ways, including in criminal sentencing. So for example, in multiple states in the 90s, judges ruled that women were required to receive Norplant as part of their criminal sentences. Additionally, during this time, 13 states offered financial incentives for women receiving public assistance if they would have Norplant placed. and 7 states introduced bills that would mandate Norplant use for some women receiving public assistance. When Norplant was on the market, it was also aggressively advertised to women of color. More recently, and perhaps more insidiously, reproductive coercion has also taken the form of programs that offer free access to LARC, but forget or neglect to also offer free access to LARC removal, or as programs that offer free access to LARC, but not to short-acting methods of contraception. These practices, although presumably well-intentioned to increase access to LARC among people who might not otherwise be able to afford it, might actually unduly influence a person's decision to use LARC, especially among folks who are socioeconomically disadvantaged. As I mentioned, coercion is not always intentional, and it may actually occur as a result of well-meaning policies or programs like those that aim to expand LARC access by offering free LARC insertion. For this reason, it's critical that those of us who communicate with adolescents about contraception understand these histories of stratified reproduction and reproductive coercion and how these might affect a young person's perceptions of LARC. For example, why a young person might be suspicious of LARC devices or feel like they're being targeted by their provider to use LARC based on their race. It's also critical that we as providers understand how operating in a society where reproduction is stratified, where we receive pervasive messaging, both overt and subtle, about who is fit to be a parent, about who should or should not get pregnant, how this influences our own biases around reproduction and contraception. We also need to understand how these biases influence our practices, including the way we communicate with young people about contraception and the recommendations we make. Reproductive justice is an organizing framework grounded in these ideas. It recognizes that every person has fundamental human rights to have children or not have children, and to raise any children they have in safe, supportive, and sustainable environments. This concept, this movement, originated in the late 1990s with Black women, and it remains a women of color-led movement. I want to acknowledge that I am not an expert on reproductive justice, but what I have learned is that reproductive justice seeks to understand how intersecting identities such as race, ethnicity, ability status, and others, how these affect an individual's ability to achieve their human rights to have children or not, and to raise those children in a safe environment. It also recognizes how systems and structures of stratified reproduction and reproductive coercion affect folks' well-being. In the context of contraceptive counseling, reproductive justice means actively working to eliminate bias and injustice. This means actively examining our own biases, our own thoughts about pregnancy and parenting, and seeking to dismantle systems of oppression and injustice, both large and small. It means removing barriers to LARC use, so those who want to use LARC can access it, ensuring that all folks have free access to the contraceptive method of their choice. It means engaging in efforts to increase access to LARC for all people, not just particular target groups. So actively working to prevent or dismantle programs or policies that either intentionally or unintentionally disproportionately target particular groups for LARC use. It also means respecting an individual's decision not to use LARC and removing LARC when requested. This means that my patient, after I counsel them about contraception, if they choose something other than LARC, I acknowledge that decision as valid. I don't see it as a failure either on my part or on theirs. And I don't walk away from that encounter thinking, oh, if I'd only done something differently, if I had only given them more information, if only they were more mature, they would have chosen LARC. I don't assume that my patient will change their mind and choose LARC down the road. So in some ways, these principles are in conflict with those of the tiered counseling paradigm, which sees LARC as the goal for all patients. And the question becomes, how do we incorporate principles of reproductive justice into contraceptive counseling? Shared decision-making is a framework that can be used in a variety of clinical scenarios where multiple options for treatment exist. And in the context of contraceptive counseling, it allows us to adopt a patient-centered model and incorporate principles of reproductive justice. Shared decision-making means that patients and providers make decisions together, as opposed to providers making decisions on the behalf of their patients. In this framework, patients are acknowledged as the experts on their own health, their experiences, and their values, while providers are considered experts on certain types of medical information. And patients and providers work together to navigate the decision-making process. The provider's role is to support the patient in making a decision that best aligns with their values and preferences. Shared decision-making is non-directive. The goal is not to get a patient to choose any particular option, but to make sure that each patient has the knowledge she or he needs to make the best decision for her or himself. In the context of contraceptive counseling, this means that my agenda is not necessarily to get more people to use LARC. It's to support patients in choosing and accessing the method that's going to be best for them. This approach acknowledges that effectiveness is not necessarily going to be every patient's top priority. For example, someone might care more about how a method might affect their bleeding. And these priorities are acknowledged as valid. This approach also acknowledges that based on an individual's patient's needs, the best option for them may or may not be LARC. The crux of this approach is that it seeks to understand the patient's goals, preferences, and priorities around contraception. A common strategy is to begin the conversation with an open-ended question, such as, do you have a sense of what would be important to you in a birth control method? Next, it uses follow-up questions to learn more about a patient's preferences regarding specific attributes of birth control methods, such as how the method is used, how effective it is, potential side effects, and so forth. This is often an iterative back and forth process, and many of the strategies we can use to guide this conversation are probably familiar to those of you who work with adolescents, who routinely engage with young people in discussions about what's important to them. For example, during motivational interviewing. We can use strategies similar to those used in motivational interviewing to discuss contraception. For example, ORs. So for example, we can ask open-ended questions, such as the one I already mentioned. We can use affirmations, reflections, and summary statements, and I've listed some examples here. Unlike with motivational interviewing, however, I'm not trying to get a patient to change their behavior in a particular way, and I don't have a particular choice in mind as an end goal. I'm really using these questions and statements to guide the conversation in a way that allows me to really understand what's important to the patient so that I can help them arrive at a decision about what's going to be best for them. We can also combine OR statements with more direct questions to get at information about specific preferences. So for example, I might say to a patient, it's important to you that your method help with cramps. A lot of methods that help with cramps also make periods go away. How would you feel about that? Or, so the implant sounds good to you so far because it lasts a long time, but you don't need to have a pelvic exam to get it. One of the more common side effects of the implant is spotting. How would you feel about that? And these back and forth strategies can be really important when patients are not particularly verbose. So a common concern is, what happens when I try to engage my patient in shared decision making, but they just say, I don't know, or they don't seem to have any particular preferences. We can use ORs, or iterative questioning, to explore patients' preferences in this setting. So for example, if you ask that opening question, do you have a sense of what might be important to you? And the patient says, no, or I don't know. That doesn't mean you have to give up on the shared decision-making model. You might say, okay, well, one thing to think about is how you would need to use birth control. So some options are medications, like pills that you would need to take every day or a shot that you would need to get every once in a while. Other options require a procedure to get started, but then you wouldn't need to take any medications afterward. What do you think about that? And so on. After asking questions to determine the patient's preferences, the next step is to provide the patient with information about each method. In my practice, I share information about the option the patient is most interested in first, or about the option that best aligns with their preferences first, rather than always defaulting to talking about LARC first. I also ask permission to discuss methods that don't align with the patient's preferences. So for example, if a patient expresses that they have a needle phobia, but that they also are interested in using a method they don't have to remember every day, I might say something like, I know you mentioned you don't want to use anything that involves needles, but that not having to remember to take a medication is important to you. One of the methods that you don't have to remember is a shot. Would you like to hear about that, just so you know what all of your options are? And finally, once the provider has shared information about methods with the patient, they work together with the patient to determine which option is going to be the best fit for them, and then to facilitate initiation of that method if the patient is ready. And Christina is going to walk you through more concrete examples of what this process might look like. A shared decision-making approach is not anti-LARC. It's really grounded in the belief that patients should be able to choose and use the best method for them, and that all patients who want LARC should have access to it. It also does not mean you can't talk about LARC first. In fact, depending on your patient population, you might find that you talk about LARC first often. However, this framework recognizes that not all patients value effectiveness over all other considerations. And it recognizes that not all patients will choose LARC, even if they're given perfect information and all barriers are removed. It makes no assumptions about which patients or how many will choose a particular method. Although contraceptive counseling is something that many providers across multiple specialties engage in frequently and something that many patients experience, there's not a lot of data out there evaluating counseling strategies. So the question might be, how do we evaluate shared decision-making versus other strategies, such as tiered counseling? And it's difficult to compare these approaches head-to-head because they have different goals. Of course, if we think about the quintessential study of tiered counseling, the Contraceptive Choice Project, it clearly demonstrated that tiered counseling can achieve its goal of getting more people to use LARC. But to compare this to shared decision-making in some ways would be like comparing apples to oranges, because the goal of shared decision-making is not necessarily to get more people to use LARC. Evaluating rates of pregnancy after counseling is difficult for a variety of reasons that we don't have time to get into detail about today. And to my knowledge, there have not been any studies evaluating pregnancy rates after shared decision-making counseling versus other strategies. We can evaluate continuation rates, so how many people continue to use their method at follow-up. And this can be valuable, but it's also important to remember this is an imperfect measure, as people might choose to change or discontinue their method for a variety of reasons. There have been a few studies evaluating contraceptive counseling strategies, and most of these have looked at outcomes such as whether the patient understand the information they received, how they perceive the counseling, or their satisfaction with the process. In 2016, Dr. Christine Dielendorf's group at UCSF found that receiving shared decision-making counseling was associated with both continuing birth control and with using a highly or moderately effective method at 6 months. And in 2017, her group found that patients who received shared decision-making counseling were more satisfied with the contraceptive counseling process than were folks who received other models. On the other hand, in 2017, Anu Gomez found that folks who perceived pressure from their providers to use a certain method reported being less likely to engage with the reproductive healthcare system in the future. As far as I know, there have been no studies looking at this model in adolescents specifically, although each of the 3 studies I mentioned included adolescents ages 16 and up. For these reasons, shared decision-making is now considered the standard of care for contraceptive counseling, at least for adults. But although there's been a lot of talk about this in the adult world, we've yet to adopt it as fully in the pediatric world. As many of you are probably aware, the American Academy of Pediatrics in 2014 recommended pediatricians consider LARC first line and use LARC first counseling for adolescents. And ACOG, the American Congress of Obstetrics and Gynecology, has also recommended LARC first counseling for adolescents. However, just last month, the AAP issued a new clinical report on LARC for adolescents. This does not replace the 2014 policy statement, but it does expand on it. And notably, it contains a lengthy discussion about reproductive justice and coercion. And it highlights the importance of counseling from a framework of justice. It also specifically advocates for adopting a shared decision-making approach in pediatric practice. This report recommends that pediatricians provide LARC counseling within a reproductive justice framework to avoid directive or potentially coercive counseling. And it recommends pediatricians focus not on increasing the use of LARC, but on improving availability of LARC. And these policy statements, these official recommendations from our professional organizations, they really matter. They not only shape the practice of pediatricians, but they shape how we teach and train future providers, our medical students and our residents, and they shape the culture surrounding contraception and LARC in pediatric practice. So I was really excited to see this new report from the AAP calling for the use of a shared decision-making approach. In summary, shared decision-making is grounded in principles of reproductive justice. It does not value effectiveness above other attributes or LARC above other options, but it may or may not consider these first, depending on the patient's needs. It uses an iterative, interactive collaboration rather than a script to convey information about contraceptive methods. And it can be tailored to the patient's knowledge and developmental status, as well as to their needs, preferences, and goals.
Great, thanks, Dr. Otto. And now we're going to turn things over to Christina Arzate.
Hi, everyone. Thank you so much for having me. I'm super excited. I'll be going over our current practices in contraceptive education and counseling here at P3, or the Contraceptive Choice Center. First, I'll go over a little bit about us. We are a family planning clinic based in St. Louis, Missouri, based on the Contraceptive Choice Project model we provide services for adolescents and adults. So while it was originally a research project, we have now transitioned into a full functioning clinic that provides counseling and methods, annual wellness exams, STI testing and treatment, pregnancy testing, and emergency contraception.
Christina,
yeah.
I'm so sorry to interrupt. I'm getting some comments that it's a little hard to hear you. I think you're kind of, it's a little fuzzy sounding.
Okay.
I know when we did our test run just before, it was clearer, so hopefully it's a simple fix.
Yeah, I'm so yeah, so let me see what I can do. I am using the same headset and microphone that I was at the
Seems a little clearer right now. Seems like we're doing better. Okay, great. Thank you.
Is this?
Sounds good so far. Better? Yes, thank you.
Perfect. Thank you for stopping.
Awesome.
And if I go back fuzzy, let me know. I'm just gonna hold it a little closer to my mouth. Yeah, that was just an overview of our clinic and the services that we provide. A little bit more about us. We take both insured and uninsured patients. That includes Medicaid. And if someone is under their parents' insurance, we let them know that we do not need parents' insurance, nor will we notify parents of any services received at the visit. For uninsured patients, we have a program called The Right Time, and it's an initiative that covers any method of birth control for someone at no cost, and that includes the actual device, the insertion, and if they came with another method, the removal cost as well. And if anyone is interested in learning more about The Right Time, please reach out to me. In brief, it is a grant that allows clinics across Missouri to offer a full range of birth control options for those who are uninsured or underinsured. And we are also a Title X subrecipient. So other services we are able to provide on a sliding fee scale based on income for our uninsured patients, and we do not require any income verification or any pay stubs, just to make that more accessible and easier for people to get services. We have a Spanish-speaking counselor on staff, but we can also arrange for interpreter services of any language. Now the choice philosophy, and this is kind of going back to how it started with the choice project, were 3 main points. One was patient choice is priority. The best method is the one that the patient will use consistently and accurately, and the patient is able to make an informed decision when they have accurate information about all the methods. So not just LARCs or not just certain methods, pill, patch, or ring, but information about all the different methods. And sometimes people hold misconceptions about certain methods that maybe they heard from other people. So we just make sure to clarify things, but not try to convince anyone into choosing any particular method. And others might not know how many methods are truly available, and that comes, I come across that a lot with my patients and how they just were not aware that there are just so many methods available, that maybe in the past the provider has offered 1 or 2 options, and we like to make sure that they know that there are various options available. So our approach is to provide birth control counseling by trained non-clinicians, aka contraceptive counselors. And this starts with asking about the patient's birth control priorities. And as you heard before with Dr. Otto, here are some of the questions that I ask my patients when I see them. Is there a method you were thinking about? Which methods have you tried before or heard about? And how did those methods work for you? And I can make note of that in the health intake form. At this point, we can just kind of get a sense of what the patient's needs are and what's important to them. Say someone comes in for their 3rd IUD or implant and they're happy with it, awesome. Our counseling session will be much shorter. Say if someone comes in and they're adamant about not having something inserted in them, as with an IUD or implant, then we talk about their apprehension, clear up any misinformation, but if they do not want an IUD or implant, then by no means do they need to get one. And if it scares them, to put something inside of them, which is absolutely valid, then they do not need to change their mind. We just try to educate everyone that comes in so that they can make the best decision for themselves. And we use various tools inside the clinic, and I'll kind of show you a little picture of the counseling room in the next slide, but some things are some method models. These are just things that patients can touch and feel, so they can actually touch and feel the IUD, the implant, they can kind of see like the actual size, the actual, just everything. The insertion device, they can touch it, play with it, to kind of get comfortable and get a good sense of that method. Another thing that we use is an option grids handout, which is attached here in the webinar. But what I like to do is I have the methods out on the table when they first come in, and that's when we just start having a conversation, very conversational, to let people really be comfortable and kind of lead the conversation. Before I bring out the options grid, because it is tiered and it is organized by effectiveness, and like Dr. Otto discussed before, so effectiveness, it's not, it's just one way that we organize the options method, but by no means does effectiveness mean better. And I emphasize that with all my patients so that they know that's just how we organize this paper, so we can kind of go through it with them. And then we talk about the pros and the cons of all the methods, should they want to hear about all the methods. We also talk about effectiveness in pregnancy prevention, how long that method is effective for, bleeding changes, additional side effects, and any additional questions the patient may have with them. So next I have a little snapshot of the counseling room. So the room is just a private room with me and the patient so that they feel comfortable bringing up any questions or answering any sensitive information. No one can kind of hear by passing by or anything like that. It's a private room of just us two. We ask that this counseling portion is just between the patient and I. So if they brought along a friend or a family member, we ask that they wait in the waiting room just for this portion, just to make sure that they can answer any questions that they had. And then when I transfer them to the provider, then we can bring their family member back to the clinic, not a problem. And this is a picture of me holding up some artwork in the clinic. So it's a pretty good sized room where we have all the methods and our handouts, and behind the table where I was standing taking this picture, we also have a wall of community resources. So my other hat, as was mentioned, that I'm community outreach coordinator. So if things come up in the counseling session or in the health intake, that say a person is bringing up that they are interested in community mental health resources, or that they are they're experiencing housing instability, we have resources to give them at that point. So why contraceptive counselors? Why is this important? So one thing is that it can save time so that clinicians can see a higher volume of patients for more clinical needs, and just making sure that we can have enough time to talk about these things with the patient, and just so that the provider and the patient is not rushed once they get to them. Also, it's peer-to-peer. Participants of the Choice Project express comfort in talking to a peer in the counseling session, the use of everyday language, and just having a more relaxed environment to talk about birth control and their needs. And also related to follow-up care. So counselors can provide follow-up reassurance. If the patient calls back later and has a question, we've already established rapport with the patient. So with me, I give my patients my direct line and tell them that they can call the main line or they can call my direct line, which absolutely happens. And they just give me a call back directly. I already know who they are. They don't have to start from the beginning of their background or anything. We've already established that. I can answer their questions and everything like that. And there's no need to always have to track down a provider or take a message for a clinician callback. We absolutely do that if we need to, but there are certain things that a contraceptive counselor is trained in and can answer those questions with the patient. So what exactly do we do? So we are the first people that patients speak with after they check in at the clinic. There is a 1 hour time slot for each new patient to be with the counselor before they see the provider. I know an hour sounds like a lot. Sometimes it's significantly less depending on patient needs, but sometimes we absolutely use that entire hour. So it's it could really go both ways. Say the patient just really wants to go through all the different methods, and we go through every just the pros and the cons, then that lots of times that absolutely does take up the whole hour, and it just might not be feasible if they were only there to see the provider. During this time slot, things that I do, that all counselors do, is I take health history, I take vitals, I go over appropriate paperwork, and since we are a Title X clinic, we have copious amounts of paperwork, and we ask about those patient birth control priorities. We give medically accurate, unbiased info about all the methods, not picking and choosing, but all the methods that they're interested in hearing about, answer any questions. The clinician is available for help if needed during this time, and just to create a positive, warm environment for everybody so they feel comfortable asking anything. Because it can be awkward sometimes. It's this might be the first conversation that someone is having about birth control or their sexual health history. On the next page, I have just a little fuzzy, but it's the options grid, and we have it in English and in Spanish. So to kind of, we have the LARCs on one side, the shot, the ring, the patch, the pill, and the condom. Again, before we even start getting into it, once I bring out the options grid, I let them know that it is organized by effectiveness, but by no means does that mean that any method is better. And then we kind of get into it. Do you want to hear about all the methods, or are there certain things that they're kind of leaning towards? I kind of check in with them, and checking in with the patients is super important throughout the whole counseling visit. Checking in how you feel, especially when we're getting into all these different methods. Just straight talking through all the methods can be really overwhelming for a lot of people. So maybe checking in after each one, or maybe after two. How are you feeling? What do you think? Just to make sure that they're still comfortable. And as you see here, we go through typical use effectiveness, how long does it last, how do you get started, what do you need to do, possible bleeding changes, other possible side effects, and then if stopped, when can you get pregnant? This is also the point where we talk about emergency contraception, whether that be pill or copper IUD. We're going to talk about that. I also allow time for questions about just sexual health at this point, just to see if there's anything else that they need to know or that they are curious about. I'm always like, I know this was about birth control. Is there anything else that you're curious about, particularly for my adolescent patients? And that's when I do get an influx of questions about sex, and then we start talking about maybe a little bit going into relationships and things like that. But yeah, and then at this point, after we kind of talk about and they choose the method of their choice, that's when I hand them off to the provider for their provider visit. And that concludes my portion. Here, just for a little bit, is my information, but also make it available at the end of the webinar as well.
That's great. Thank you so much, Christina. And we've got some time, as we said, that we protected for questions. I'm going to share my screen again momentarily. And then I'm going to read some of the highlights of the questions that we've gotten. We've got some great questions in here. Just one moment. Great. Okay. So I would like to start with kind of fielding the question that quite a few people had about what we're going to be sharing afterwards, and if the resources that we've discussed here, and if the recording is going to be available. And I just wanted to let people know that we're going to be sending a follow-up email that will include the recording. I also really appreciate that one of you out there in participant land suggested that we provide a transcript for hard of hearing individuals, and so we will have a transcript as well of this entire presentation. Someone just asked the question about the contraceptive options sheet that Christina shared at the end, and we can share a couple links. I know that there are a few that are out there. One is from Bedsider. The one that Christina shared we have access to, and so we'll share all of those as resources in the follow-up email. Jumping into some questions now. I kind of want to start with a suggestion and a comment that is, I really appreciate that this participant shared, and they said that it was they were comfortable with me reading the comment here. So I wanted to share with you all. I am non-binary, and I'm always aware of information presented through a binary lens. I highly encourage information to be presented to people in a gender-inclusive way. It can be as simple as removing he and she from language and replacing it with they and them. Also, removing gendered language from body parts such as people who menstruate, people who ejaculate. Being non-binary and working in this field is incredibly frustrating when myself and other non-binary folks are left out of or alienated from these important conversations, and thank you. And so I want to thank this person for sharing that as a good learning for all of us. And then I'm going to move into a question from, let's see, about how do we incorporate STI questions in there as well. This question came in during Dr. Otto's presentation, so I'm going to pitch it to you, Dr. Otto. How do you incorporate STI questions in there?
Sure, thanks, Jenny. I think I generally am sort of thinking about those questions as not a separate conversation, but not necessarily embedded in the conversation about contraception if we're thinking about prescription methods. But certainly, and whatever method my patient chooses, I will follow up with them about condoms and emphasizing that none of the methods that I can prescribe will protect against sexually transmitted infections, and that dual protection with condoms is the only way to prevent against STIs or reduce the risk of STIs. So I usually will sort of keep that as like a follow-up once the patient has decided on a method, rather than embedding questions about STI risk or conversation about that in my back and forth process, thinking about specific birth control methods. I don't know if Christina has anything that she would add or suggest.
Yeah, so that was a really good question. For us, we also kind of after, sometimes it'll come up during the counseling session, but we'll get into more detail after the method is chosen, when I start getting to talking about condoms and how to use a condom and everything like that. And that's the only one, like you said, to prevent against STIs, and then we'll kind of, it'll be more from my end, a little more brief, but then I will check in with the clinician to let them know that the patient is interested in kind of more detailed information about STIs. And so it'll kind of start with me, but the more detailed stuff will come from the provider.
Great. Thank you so much. We've got lots of good questions coming in, and so I'm going to move kind of quickly. There were a few comments and questions since we're on the topic of STIs, so I'm just going to kind of collect some of those. So one person asked, is there no mention about STIs? I'm thinking that may be kind of in the overall approach, which I think was just covered, but also in the grid handout. And so as I mentioned, we'll share a few different options for different grid handouts from different places. One person suggested that they like the one from the Family Planning National Training Center, which will include that link as well. That some of these include information about STI protection and some don't. And so someone asked the question, why isn't STI critical information not included in the grid handout? Research shows LARC users have increases in STIs. So I'm going to put that comment to you all, Christina and Alana.
Yeah, so the options grid came from specifically the choice project that was several years back, which the focus of that one was just on birth control. I have another one of other options handouts that I use in the clinic that does include things beyond these methods and including STI handouts that I use in the clinic that I can absolutely pass on. This was just kind of one option grid that I use, but I can absolutely pass on even more information that I use as my teaching tools.
Cool. We will compile those and coordinate with you afterwards so that everyone can benefit from it. Thanks. Dr. Otto, do you have anything for that to add, or should I move on?
I think the thing that I would add is just that I absolutely talk about infections and reducing risk of infection hand in hand with talking about contraception, and didn't get into the details about that conversation here today because there were time limits. I think we could talk for hours or days about this topic and all of the sort of concepts that are really closely related to it. So I do want to acknowledge that conversations about STIs are really important and a really important complement to conversations about contraception, and not something that we had time to really delve into in detail today.
Thanks. Okay, next question. A lot of these tips sound amazing for one-on-one birth control counseling. Any suggestions for teaching about birth control methods in the classroom? Is it still best practice to talk about all options in order of effectiveness, as long as the information given is in a non-judgmental or neutral way?
Yeah, that's a great question. And I am not a sexual health educator, so I don't know that I'm the best person to comment on what is best practice in the educational setting, but I completely understand that if you are talking with a classroom with dozens of students, that you're not going to be able to tailor the messaging to each individual's preferences or priorities, and you have to start somewhere. You have to organize that information in some way. I really like the grid that Christina showed in her presentation from the Contraceptive Action Plan, because while it organizes information in order of effectiveness, it also contains information about different dimensions, different attributes of methods, versus a lot of other visual information only references effectiveness. So I really like that that one has information about side effects, how it works, how long it lasts, effects on bleeding, all of that information that might matter to folks. And so I think in situations where you are presenting things visually, or where you're communicating with a large group where you can't have that shared decision-making kind of conversation, I think that can be a nice way to highlight other priorities and other effects in addition to effectiveness, while keeping in mind that you have to present things visually somehow, and that it's not, I don't think it's wrong to use a tool that is organized by effectiveness.
Great. I'm going to do a quick time check. I know that it's 2 minutes until the end of the webinar, and if our speakers are willing to stand for a couple more minutes, we have a lot of great questions still. Are both of you able to stand for a couple minutes after?
Absolutely.
Great. Okay, I'm going to flip through a couple of our closing slides just to kind of wrap that up, and then I'm going to come back to our questions in just a second. I want to take this moment while you all are here to just recognize that Adolescent Health Initiative is offering another training that is coming up soon. 2 days left to register for it. The training's on October 6th and is on practicing adolescent-centered trauma-informed care in a clinical setting. So we encourage you to join us for that, and just to follow us on social media. So I'm going to leave that slide up so that you can stay in touch with us for other kinds of events like this. And then we have lots and lots and lots of free resources on our website. One that we're working on right now with Dr. Otto to help health centers provide access to same visit LARC. So we're going to have a number of resources coming up that are in the pipeline, but we've got lots on there. So check us out sometime. All right, coming back to some of these great questions, here's a question that says, do you know if providers are ever incentivized to promote LARC or LARC continuation? I have heard this as a concern for aggressive LARC promotion or providers being reluctant to remove a LARC device.
Yeah, that's a great question. I know that in my own experience, this was several years ago, but in the state of Illinois, in an effort to increase LARC use, the state increased reimbursement rates for providers for inserting LARC for patients with Medicaid. So the Medicaid reimbursement was increased. And, you know, I think at the end of the day, the Medicaid reimbursement rate probably doesn't have an effect on the provider's salary, most likely. So I don't know how influential that change was. I don't know how many providers were actually even aware of that. My guess is that many providers didn't know that that was actually happening because they don't see what they're being reimbursed by Medicaid. That's the only specific example that I'm aware of. I think what I am probably more familiar with are instances where there are more insidious incentives for providers to provide LARC, and just kind of this pervasive messaging that we receive throughout training and throughout practice that LARC is best, and that particular groups specifically should be using LARC.
Thanks, Dr. Otto. Here's one that is a kind of a longer point, but I really want to be able to read it because it contains a lot of great stuff. So here's a comment question from someone. The overview of both tiered counseling and shared decision making was good, but I felt like they were presented in a way that makes them mutually exclusive. But in practice with teens, it feels like the most patient supportive conversations is a combination of the two, with the ultimate goal being to understand the patient's needs and help build knowledge about method options based on their personal goals and needs. For those patients whose preference is centered around effectiveness, then a tiered method description may be an important structure to use, though keeping in mind that the quote, right choice in the end is the choice that feels the most right for them and their needs. So I'm sure that I know there are different schools of thought as our opening poll kind of captured on this. And I just wanted to put that out to either of you to see if you had any responses.
Yeah, thanks, Jenny. I think that's a really important observation, that what we do in practice might be a combination of different strategies. And I think I mentioned before that depending on your patients, depending on the individual preferences and needs of your patients, you might actually be doing LARC first counseling very often if that's what's important to your patients. And certainly there's nothing wrong with that if you're responding to the needs and the preferences of your patients. And I think using that tiered strategy, even if that is your default, there are opportunities to incorporate that shared decision making with the patient. So as you're moving through that list of options, organized by effectiveness, asking questions about other things that might be important to them too. So questions about bleeding, about side effects, about privacy and return to fertility and all of those things, and incorporating that as you move through that conversation. And I know, as Christina mentioned, she structures the conversation in a different way than I do, I think, and I don't think any is right or wrong. I think the point that I was trying to emphasize was that coming in with this sort of a priori assumption that LARC is going to be the best choice for every teen is what I want to avoid.
Thanks. This is a question for Christina. So how has COVID-19 changed the C3 method of counseling for individuals coming in under Title X, and especially youth?
Yes, awesome question. So COVID definitely altered our counseling and the way we do counseling. So what we transitioned to doing was offering telehealth visits with particularly phone calls with the contraceptive counselor. So they were still getting that dedicated time with me on the phone. But what I was doing was calling the patient and making sure that it was pretty flexible on the time, since we were all kind of working in different places, and making sure that they were that it was a time that they can pretty much choose which time I called them. I was pretty flexible. And then even more important, to check in to see if they're able to talk freely, especially with you. Because it might be one thing to say, to ask, are you somewhere private? Can you go somewhere private? But a lot of the times, if you're in your parents' house, there is nowhere that you can go that is private, and I speak from experience. So that was even more important to make sure that I'm doing the counseling, still providing information about all the different methods. For a while, we were mainly doing phone and not video, but we did have a video link for YouTube to share so that they can see the methods visually. But it was primarily through telephone, talking with the patient, going through very similarly to what I do in the clinic, but just making sure that I'm being very descriptive, checking in more, making sure that they feel comfortable wherever they are to talking. And that might mean, instead of using it, which actually this is from a patient that I had, is not always, so this is why I sigh, because I always like to use very like open-end questions to have the patient lead the conversation. But if they're not able to be in a private place. You know, it might not be, I might have to kind of ask questions so that they're able to say, give me answers that are not, that cannot be traced to what the conversation that we were talking about. So instead of describe, say we're particularly for when we were doing not just contraceptive counseling, but this was also with like someone that wanted to come and get an appointment for like testing or had questions about STIs, instead of leaving it open to like what symptoms are you having, it would be more so like I would state different symptoms and I'm like, okay, now you can tell me yes or no, to make sure that no one listening can kind of trace back to what we're talking about. So that was a big transition during COVID, especially with youth, that we did over here.
Thanks, Christina. I think that what I'm going to do, I've got a couple requests to go back to the slide that has the bit.ly for the upcoming virtual training that we're doing on trauma-informed care. So I'm going to put that slide back up. And then, because some of these, a lot of these questions have to do with resources or access to resources, whether it's about the contraceptive options charts, and a couple of other questions that I think will be easier for us to handle in that follow-up email, keep your eyes out for that. We're going to share, we have a lot of resources that we have access to that we share with our partners, and we compile those and curate those from around the country. So those resources we'll put in that follow-up email. And I just want to take this moment to say a thank you, a huge thank you to both of our presenters, Dr. Alana Otto and Christina Arzate, and for their expertise and their perspectives on this really important topic. It's complex. There's still comments and questions out there where people are kind of weighing in about the importance of talking about abstinence, and I want to acknowledge that. I want to acknowledge people's concerns about incorporating those conversations around dual protection, around sexually transmitted infection and pregnancy prevention. So many great issues raised here, and as Dr. Otto said, it would take days for us. And so maybe our next connection session is going to be a more complex look at the ways that we talk to young people about preventing STIs and preventing pregnancy, and also not just prevention, but proactive caring for themselves and taking charge of their reproductive health and their fertility and reproductive destiny. So many thank yous to our presenters and also to all of our participants for their great questions and for being with us today. Again, look for that follow-up email, and we hope to see you on other kind of learning opportunities in the future. Thank you all and have a great day.